Hello and welcome. On behalf of CME Outfitters, thank you for joining us for today's CMEO briefcase titled Applying Patient-Centered Pain Care to Practice, a case of unrelenting post-traumatic pain. Today's program is supported by an independent educational grant from the Opioid Analgesic REMS program companies. I'm Dr. Melissa Weimer. I'm an associate professor of medicine and public health at Yale School of Medicine and Public Health and the medical director of the Yale Addiction Medicine Consult Service in New Haven, Connecticut.
Hi, I'm Dr. Lynn Cohan. I'm a professor of anesthesiology and pain medicine at the University of Virginia. I'm the division chief as medical director, as well as the program director for the Pain Fellowship.
So the goal of this educational activity is to empower learners to educate patients about their pain so that we can optimize safe and effective multimodal treatment plans. So can you please tell us about the case of Marie?
Sure. So Marie is a 32-year-old female who about 6 months ago was in a motor vehicle accident in which she was rear-ended and reported kind of suffering like a whiplash at the time of the accident. But since that time, she's been experiencing persistent neck pain and almost daily headaches after this accident. She describes the pain as essentially a deep ache, and it's constant in her neck that radiates to her head and sometimes radiates into her shoulders. And it's just increased in severity since the accident. She did get x-rays, cervical spine x-rays, about 1 week after the motor vehicle accident that was negative for any acute pathology. So there were no fractures or anything like that noted. So her PCP had recommended over-the-counter pain relievers to try to help with her pain symptoms, and nothing has really helped so far. She's on some other medications, so she's on sertraline 50 milligrams daily. She's been taking ibuprofen, Tylenol, oral contraceptives, or her medications. She has a past medical and social history for depression and anxiety for about 10 years. She has average weight and build. She drinks alcohol socially, but denies any tobacco or illicit substances. She lives alone. She has no spouse or no children, and she's employed full-time as an account manager.
Great, thank you. So let's think about this case. And based on the duration that was described, Marie's pain would be classified as which of the following? Please pick one of these options here. And the answer here is chronic. And the reason that it's chronic is because it's lasting 6 months, which is longer than the kind of cutoff that we typically have of 3 months when you go from acute, subacute, or into chronic pain. So once pain persists greater than 3 months, we're really getting more into the chronic pain category.
And so, she's 32 and she was in this accident, but, most people recover. As Dr. Weiner just said, you kind of had that transition from acute to chronic pain. So, patients her age often recover from this type of accident, but her pain has persisted. Other pertinent things, so we want to think about what is pertinent in the history that draws us to why she might be having this pain. So she's reporting this deep ache and stiffness. So often patients can have this from potentially what we call myofascial pain, so pain that's coming from the muscles, or also could be pain that's coming from the bones, particularly after a whiplash type injury. Her x-rays were negative, so it didn't show any specific structural damage. So again, this is a good thing, right? That she didn't have any fractures or any kind of misalignment that was occurring after this accident. She's been using the over-the-counter pain relievers, but really, they haven't been helping. She also is reporting headaches. So headaches can occur sometimes because people with neck pain can have referred pain into their head, but there's also concern that people with headaches can, when they're using over-the-counter medicines on a daily basis, can also have rebound headaches. So potentially something to think about is one of the reasons why her pain might be persisting is that could she be having a component of rebound headaches just from the treatment from the myofascial pain that was initially initiated. She's also, has this history of depression and anxiety. And so, a lot of people suffer from depression and anxiety. But you always want to look deeper into this for patients who are presenting with chronic pain. There can often be a cycle of pain and depression and anxiety where essentially one worsens the other. And so this is also something that we need to kind of delve potentially deeper into. And her social history shows no immediate concerns for any kind of substance use disorder. As of now, that's not something that we're thinking about more. So in terms of what we're thinking about, she's got this neck pain that's largely axial, so it's not particularly radiating in nature. And so when we think about that, we're thinking more of mechanical pain, so myofascial pain. So again, pain coming from the muscles, or things like spondylosis, which can be very common after a whiplash injury in the cervical area. Disc herniation is probably less likely because she's not reporting those signs of radiating pain down into her arms. So how do we kind of, do the chronic pain assessment? So, we have her history. We have the pertinent information from the history that it's axial pain, it's deep, it's aching. So less, neuropathic in nature. Neuropathic pain is typically described as like burning, stabbing. So again, kind of thinking more of this musculoskeletal type pain. But next, we want to perform a thorough physical examination to kind of help us determine what her diagnosis is. And it's also very important to do a psychological and functional assessment, as well as some diagnostic studies and an opioid risk screen. She's not on opiates now, but again, important part of a comprehensive exam for pain assessment. Dr. Weiner, do you have any thoughts on the chronic pain assessment?
Yeah, I would just say, this can take some time. So it's important to give it the time that it's due. I think many times we try to rush through these evaluations, and I understand why, but I guess what I see is that sometimes this pain kind of persists longer than you would expect it would initially. And I sometimes see that happen when folks don't get the thorough evaluation they need from the outset. So I think that although it takes time in the beginning, if we can invest that time in the beginning, it may actually save you a lot of time in the end and really be better for the patient and help them get better. Because once pain persists for a long enough period of time, like that can also, start to develop a lot of challenges for the patient. So we want to try to, if we can, really adequately treat this as quickly and safely as possible.
I definitely agree with that. And I always talk to patients how, I had mentioned before how pain and kind of these other factors are cycle, right? And they each can worsen each other. So pain is not just a physical experience, it's a physical and an emotional experience. And that's by definition of what pain is. And so you need to talk to them about both these aspects. And so, the pain pathology, there's their inflammation, and that's the physical aspect. But, how are they dealing with the pain? It's when you're suffering pain and you're decreasing your function because you can't do things because of that, that can cause stress, that can cause worsening depression because you're losing your quality of life. And those depression and anxiety that goes through that, I talk to patients how that kind of releases these stress hormones, and those stress hormones can then feedback on the pain pathways and worsen pain. And then that worsened pain again kind of feeds back to this the emotional state, and it just can be spiral out of control. So to Dr. Weiner's point, the getting ahead of this and trying to stop that cycle early is really important. And so, things like sleep and nutrition, all these things are really important. And you really need to ask patients about that. What kind of support do they have? How are they sleeping? How are they coping? And then really address those if you find through certain screening or assessment tools that there are issues. So certain assessment tools that you can use are things like the McGill Pain Questionnaire, the multi-dimensional pain inventory, the sickness impact profile, the illness perception questionnaire, coping strategy questionnaire. There's really many. There's catastrophizing, there's fear avoidance scales. There's a lot of different scales that can be used to kind of get deeper into some of these psychosocial assessments. It's also equally important. We talk so much about pain, and patients, obviously they're coming for evaluation of their pain and they want to talk about their pain, but it's really, really important to think about function, right? That, a number of pain doesn't tell us as much about how patients are functioning. A pain scale is subjective. So one person's 8 could be another person's 4. So really what you need to find out is, how is this impacting, or how has this changed their ability to function? How has it changed their ability to do things with friends, or whatever their goals are? And so this is an important aspect to think about too. And so there are functional assessments that you can do this. Um, the PROMIS scale, the PEG scale. There's many different types of scales that can be used. I mean, in terms of which one to use, which is better than the other, as long as you're using a validated scale, I think it's okay. Ideally, probably don't have one, pick one that has 40 questions, or shorter sometimes is better, particularly for screening. But also equally important to identify the functional goals of the patient. What does the patient think that they can do and want to do and they can no longer do?
I'm just curious, Dr. Cohen, is there one scale that you typically use or you like most in your practice that you find the easiest to use and maybe the most helpful?
I mean, I think the PROMIS scale often, but sometimes also depending on the type of pain, like for knee pain, there's different scales for knee pain too. So some of it depends on the type of pain that the patient is experiencing.
Do you typically use the McGill pain questionnaire, or more of like the brief pain inventory?
The BPI, yeah, the BPI is a good one as well. When you're also doing this kind of thorough assessment, you also want to make sure that you're not missing red flags, right? You never want to just assume, okay, that everything's good. This is a young patient, there's nothing wrong on the x-ray, so everything's good. And like, you still want to ask questions to rule out red flags. So red flags could be things like infection, an inflammatory condition, malignancy, myelopathy, and some kind of vascular emergencies. I definitely, seen patients who are young, who have had persistent pain and who have had, conservative treatment and even injections, to get further imaging to found out that unfortunately they did have a metastatic malignancy that had not been detected before. And so it is important to kind of think about these other things and really, ask them questions, to rule out things. Are they having fevers, night sweats, make sure, ruling out infection, weight loss, things like that. Kind of moving on to our specific patient, Marie, again, we're going to kind of look at some of her physical exam findings and kind of things that, and some of the notes from her pain assessment. So she reported that, she really was having more difficulty doing daily activities, and that she's actually missing work now because of this pain. So 2 to 3 days off of work per month since the pain onset. She used to run and hike and swim and do all these things, but now really stopped all these things since her injury. The pain is worsened by neck movement and is partially relieved by rest. And she becomes really tearful during the visit, because the pain is now controlling her life. And she really has given up everything since this happened. She's also complaining of, inability to sleep, fatigue, and getting, worsening depression since the injury. On physical exam, she's found to have normal gait. There's no visible deformities. Her neuroexam, there's no notable weakness. Her sensation is intact. There's no signs of myelopathy, and her reflexes are intact. She does have some decreased range of motion, and the X-ray, an X-ray showed no acute findings, no disc space narrowing, no misalignment, and is stable compared to the one that she had, a week after the accident.
Great. So let's ask another question. Let's go back to the audience and let's break down Marie's pain assessment. So what finding in Marie's pain assessment is suggestive of catastrophizing? And the correct answer would be A, states pain is controlling her life and fears it will only get worse. So again, speaking to this idea that, she's not going to get better. Things are only going to get worse. And she's basically doesn't feel like she has control over this pain or herself any longer.
No, I mean, any patient in chronic pain can have catastrophizing, particularly in this patient. She was in a motor vehicle accident. That's a stressful event. It's a scary event. And so that can add to it. And so, some of the things that suggest perhaps there's more going on than in terms of the biopsychosocial models. The fact, luckily, her imaging has been normal. You had found no red flags on her physical exam. And then things that she's saying, she's spending a lot of time thinking about her pain. She's expressing these fears of worsening pain. She's avoiding activities. So that's this fear avoidance where people with chronic pain no longer, do things because they're so afraid that it's going to worsen their pain. They're going to be worse off later. Also, her worsening emotional state, the insomnia, she's reporting herself as worsening depression. These are all areas of concern that definitely need to be addressed and treated. And it's part of a disease process. I think that's really important to understand, is that a lot of patients with chronic pain who are having worsening depression, potentially catastrophizing, can often be stigmatized. And I think it's really important as the clinician to make sure that you're not stigmatizing patients. That's not some kind of personal failing, that it's part of a disease process, and that it should be treated the same way any other medical condition should be treated. And so, what are some of the things that we can do? And so you definitely want to employ multimodal treatment. And so this involves, physical treatments as well as psychological treatments. So cognitive behavioral therapy could be really important. In these cases, we have a pain psychologist who's in our clinic, and we often refer patients there. It's really important how you frame this to patients. Some patients, think that when you mention pain psychology, that means you think, oh, you don't believe me, this is in my head. It's really important to describe to them that, again, the pain is physical and emotional, and we need to treat all aspects of the painful condition, and that we're really not going to make as much progress if we're only focusing on one small area and not a more comprehensive approach. And so cognitive behavioral therapy can be very important in this. Physical therapy, getting patients moving, is also really important. And that might be hard because they're having that fear avoidance, they're afraid to move. But if you can kind of combine that cognitive behavioral therapy, that pain reprocessing therapy, along with physical therapy, you can really see greater strides. And medications as well. So you can certainly use over-the-counter medications. There are other medications that can potentially help for musculoskeletal pain. Duloxetine is becoming more common treatment for musculoskeletal pain and is approved for that purpose. And potentially interventions. And so you can potentially do trigger point injections for the myofascial component of the pain, because she's young and she experiences whiplash. And we talked earlier about how spondylosis can be common after that situation. You might do something called cervical medial branch blocks, where you're actually kind of targeting the little nerve that supplies the joints. If there's some irritation in there, as a diagnostic procedure, and then you can do an ablation after that if that proves to be diagnostic. Dry needling, acupuncture, really just thinking about lots of different types of things. Now, I had mentioned duloxetine, which is a selective neuropathy and serotonin reuptake inhibitor. She is on sertraline, and so you would need to be careful not to just add on the duloxetine for a patient who's already on an SSRI, a selective serotonin reuptake inhibitor, because that could potentially precipitate serotonin syndrome. And so you would kind of think about, can you do this switch? The patient's on this already for anxiety, depression, and it's really helping them. I might be reluctant to have them come off and start duloxetine. But, if they're saying, no, it's not really working that well, then that might be more consideration to do that change. But I usually always do that in conjunction with the prescriber, whether that be the psychiatrist or the primary care physician who started it and who may know the patient better from their psychological standpoint. Dr. Weimer, you have any other thoughts on that?
Yeah, I mean, I think other things that I would want to think about doing for this patient are, it sounds like she doesn't feel like she has control over the situation. So perhaps having her do very active components. So medications are passive, it's something you're taking, you're not necessarily doing something active. So I think to the extent we can help her understand that cognitive behavioral therapy is an active therapy, physical therapy is an active therapy, exercise therapy is active. And so all of that sort of helps her take back control of the situation and understand that she actually is at the center of the treatment, right? These other things are around her, surrounding her and supporting her, but really the key to helping her get through this and manage this is her own actions. And so to the extent that we can help support her to do that, I think that can be really, really powerful. Not saying that taking a medication means she's not, taking care of her health, but just not to have full reliance on the medications,
Yeah.
because I think that's where we get into some of the issues with people who are maybe only relying on, NSAIDs or acetaminophen or opioids to manage their pain. And we know all of those things have risks.
I definitely agree with that. And I think to that point, also kind of small, attainable, functional goals, like she was running and hiking and swimming, right? Can she do all that like, tomorrow? Maybe not. But, what can she do that's a smaller step that's achievable that she'll feel successful in doing, and that she can gain confidence and maybe hope to lessen that kind of fear avoidance when she realizes that, it's a stepwise process.
I would also imagine that she probably feels pretty, negative about herself as a very active person prior to this happening, as you said, like to what extent has that changed her feeling or thoughts about the pain? And so helping her understand that, it's hurt, not harm, even if she's doing something and it's causing a little bit of pain, if once you've, evaluated and you've thought about those red flag issues, if there isn't a red flag issue there, and this is a lot of myofascial pain, then actually movement can be the medicine to help treat it. And so really kind of a lot of reassurance and getting her active again.
Definitely agree with that. We see that a lot in fibromyalgia too, where patients it hurts to move, but the patients who get better are really the patients who kind of stick with it, because you're getting that functional gain later on. And, really important to educate the patient about all the stuff that we've been talking about. And so, educating the patient again, that it's not, so you're not stigmatizing them, that, that all these things link together, and that, again, that they do have that active component, that they can do active things like the mindfulness and different things like that, to lessen their overall catastrophizing type experience, because these are things that really have been shown to actually impact outcomes. If we can educate the patient and kind of get small acceptances and help them through the process, those are the people who are really going to do the best. And as was said, it's not just reliance on a medication or a quick fix. I talk to patients, this is a process. If you have this pain for 6 months, it's not going to go away after one visit. We're going to work with you. We're going to see you back. We're going to help you through this process. And also realistic expectations, kind of like I talked about, like, is she going to go back to kind of hiking 5 miles on day one? Possibly not. But having realistic expectations and realistic goals that are achievable and that we can increase throughout the time of her treatment to get her back to where she previously was. There's many different types of patient educational tools. And so there's an example here in the slides of one of the type of educational tools, it's kind of saying, again, going back, I think, to that thing about the active choice, choose 3 things from the cycle that you want to take action on now. So it's really important to be in a mutual process with the patient, and that you're not choosing the things that the patient should be doing, that the patient is actively involved in what they want to be choosing. I think it's important. And there's many different types of resources and handouts that can help with this. There's infographics, there's videos, to teach patients about pain and different self-management strategies to help them through. So in general, kind of the overview of Marie's pain and her treatment plan and her follow-up plan. We discussed with her, definitely would want to discuss with her fear avoidance, cycle, and self-management strategies. She's, can be provided with some take-home resources for further education. So, she kind of identifies her goals as kind of walking at least 1 mile 3 times a week, reducing her missed work days to less than 1 time a month, and practicing mindfulness for 15 minutes 3 times a week. Medications, we talked about maybe discussing with her prescriber her sertraline, potentially switching to duloxetine, and referring her to physical therapy, then following up with her in about a month, considering MRI if she's not getting better. But from all signs, I think she will improve, and potentially definitely that referral to pain psychology. I would, definitely talk to her about that at this first visit and kind of get that set up for her, so she's actively involved in that process.
That's great. So thank you, Dr. Cullen, for your insight. I think we've learned a lot today and had a good discussion about the case. So if we pull it all together and thinking about our own SMART goals to apply to our practice, after today, we hope that participants will be able to perform a thorough pain assessment, including the psychosocial and pain-related functionality assessment in patients who have chronic pain or who have gone on to develop chronic pain, identify fear avoidance and catastrophizing behaviors in patients with chronic pain, develop evidence-based multimodal treatment plans for patients with chronic neck pain, as we discussed in this case, and provide education to patients about their pain and self-management strategies to disrupt ongoing chronic pain cycles. So this is a series of several other brief cases, and we would encourage you to check them out. They're all listed here, and you'll see lots of different principles discussing different facets of pain care throughout the brief cases. These activities, as well as many other educational activities for clinicians and patients, can be found online at the CME Outfitters Opioid and Virtual Education Hubs. If you would like to receive continuing education credit and a printable certificate for completing today's activity, we do need you to complete a post-test and evaluation online. Thank you for participating, and we hope that this helped you to be able to provide the best care for your patients. Thank you so much.
Thank you.